Hi, everyone. My name is Isaac Armistead, as I was already introduced, and uh, I am happy to be here today with my colleague Elizabeth. We're going to be covering the following topics with regard to flu and RSV, talking a bit about the basics of these viruses, as well as the transmission, how they spread, what the methods we have available right now to prevent each of these viruses, as well as treat them when needed. And then finally, reviewing some of the guidance regarding outbreak management, specifically in the correctional facility setting. The objectives today are to increase knowledge of the basic characteristics of flu and RSV and how they spread and cause disease among people, as well as to increase knowledge about the reporting requirements for outbreaks, how this is done, and then what some of the concepts for management of these viruses in the correctional setting would be. And then finally, to increase awareness about immunizations that are available not just for flu, but now also for RSV as well, which is an exciting change this year. And we'll review some of that in a bit here. First, we'll start by talking about influenza and some of the basics that you may be aware of, but if not, hopefully give you some level set some knowledge here. Influenza virus has several types. The types A and B are the two most common in humans. And specifically, in any given season, the subtypes that we look at for flu A include H1N1 and H3N2. And then for B, there are different lineages. The two lineages we in the past have seen most commonly include Yamagata and Victoria lineages, although some of that may have been changing since the pandemic. The symptoms of influenza illness are familiar to many of us and can have a variety of presentations. But in general, symptoms typically start about 2 days after an infection has taken place. The symptoms can come on suddenly, in contrast to other respiratory viruses. And then some of these symptoms can include fever, a cough, sore throat, runny nose, body aches, headaches, and fatigue. And then sometimes gastrointestinal illness to include vomiting and diarrhea, but that can be variable. And again, all of this is a bit more general in the way I'm speaking about these right now. So an individual person's experience may be different. The peak of contagiousness for an infected person occurs within the first 3 to 4 days after symptoms start, which is an important consideration when thinking about infection control. And also important to remember that primarily the spread of influenza occurs person to person, primarily, you can see we're really emphasizing primarily here through droplets, virus-containing droplets, as opposed to contaminated surfaces or airborne particles. Those can be methods of transmission, but they're not thought to be the primary method by which influenza virus spreads. And then lastly, I wanted to emphasize the groups that are at highest risk of complications. This is important, particularly when thinking about the settings in which people live and treatment of influenza, the extremes of the age spectrum, so older adults, and by this CDC generally defines 65 years and older. Young children, the youngest infants and toddlers in particular, but young children generally. And then individuals who have certain underlying conditions. And the full list of that is a little more extensive than what I can go over here. But many of the underlying conditions that put people at risk generally for severe respiratory illness would apply in the case of influenza as well. And with that, I'm going to hand over the presentation to my colleague, Elizabeth.
Thank you, Isaac. Good morning, everyone. So I will be talking about some of the different surveillance systems that we use in Colorado for influenza activity. So this first slide shows the total number of influenza-associated hospitalizations statewide, beginning in October of 2021 and extending through May of 2023. So for comparison, the hospitalizations during the 21-22 season, which is shown from October 2021 to June 2022, were considerably less in comparison to our most recent season, October 2022 to May 2023. And as you can see here, the flu A cases were predominant in both seasons, with the flu A H3N2 subtype being the most commonly detected strain, with flu A and H1N1 cases also making up a proportion of those detected during the 22-23 season. So we've had a handful of cases reported since September 1st, roughly about 20, but no surge in cases yet, but we are getting those reports about influenza admissions statewide. Next slide. And this slide shows historical trends of influenza-associated hospital admission rates during the previous 5 seasons, beginning with the 2017-18 season. So hospital admission rates related to influenza-associated illness are used as an indicator of disease severity and its impact on the population. So this season, the 2017-18 season, was highest in comparison to the others shown here. And the most recent 22-23 season trends about second in terms of admission rates per 100,000 people. And just to describe the MMWR weeks of admission on the horizontal x-axis are, to explain MMWR weeks, those are the week of the year that correlates with the reporting of infectious disease data, and that is used by the National Notifiable Disease Surveillance System. And so as you can see, some seasons also show one peak of activity, such as the 17-18 season, while other seasons reflect 2 seasonal peaks, such as the 18-19 season, with a peak during MMWR weeks 52, which is about the end of December, the last week of the year, and MMWR weeks 10 to 11, which is roughly about mid-March, the time frame. And so you can see that the 22-23 season peaked the earliest of the past 5 seasons during weeks 46 and 49, or from around late November to mid-December. So it's not uncommon to see 2 seasonal peaks during flu seasons, generally one occurring around the November to December timeframe and another in the spring. And generally, we often see 2 different flu subtypes contributing to those different peaks. And other times we have seen 2 seasonal peaks with the same subtype as well. Next slide. So the above graph shows percent positivity of influenza in Colorado from October 2022 to present. So this data is reported from 26 Sentinel Hospital laboratories every week across the state of Colorado. And it indicates the percent positive influenza specimens among the total number of specimens tested for influenza at that particular lab. And the graph also shows data on the detection of what percentage of those specimens were flu A and flu B. And just to mention, currently flu positivity is extremely low. It's at about, I would say, 0.6%. We have seen, again, the reports of hospitalized cases, but currently it is very low. So we have, we'll have yet to see if cases will start to increase in the next couple of months. Next slide. So to go over what influenza-associated conditions are considered reportable to the state in Colorado, there are 3 different related conditions that are considered reportable. So the first is influenza-associated hospitalizations. Those are considered reportable statewide year-round. And so I will mention that the official surveillance season starts on October 1st, which is this coming Sunday, and extends to the end of the 3rd week of May in the following year. However, we do tend to see some flu cases outside of that time frame. And so we want to emphasize that hospitalizations are reportable year-round. And the definition for this hospitalization includes all patients who are hospitalized and had a positive flu test during their hospitalization or within the 14 days prior to admission. And then secondly, pediatric influenza-associated deaths are reportable statewide year-round as well. So any cases of death where it occurs among a child that is less than 18 years of age, that's considered reportable to the state immediately. And third, influenza-associated outbreaks are reportable statewide year-round in residential and long-term care facilities, as well as correctional facilities. Next slide. So to cover what the outbreak definition would be for a flu outbreak at a correctional facility. So a suspect outbreak would be if you have 1 confirmed case of influenza, and that confirmed case would be confirmed via testing among incarcerated or detained persons, or IDP, among 1 or more other IDPs with undiagnosed respiratory illness with symptom onset occurring within a 1-week period. And then a confirmed outbreak would be at least 2 or more confirmed cases of influenza among IDP with symptom onset occurring within a 1-week period. And we do have a specific guidance document for influenza outbreaks in correctional facilities on outbreak prevention, mitigation, infection prevention, and how to go about reporting that outbreak to CDPHE and or your local public health agency. And we're currently having this guidance approved, and at the link below is where you'll be able to find it. Currently, our 22-23 season guidance is on the website and can be used in the interim until we have the more recent guidance posted. Next slide, please. And just to give you an idea of how many outbreaks actually occur in correctional facilities in Colorado. So this graph shows our data from the most recent season, October 2022 through May 2023. And so this shows where the outbreaks occurred by facility type. So you can see that the majority of outbreaks occur in residential care facilities, but we do tend to get reports of correctional facility outbreaks as well. And just for reference, in the table on the right, we have numbers showing how many outbreaks occurred in facilities by season in past years. So in the 1920 season, we actually had several. So we had 18. And then the 20 to 21 season, we had 0. And if you'll remember, of course, that was during the COVID-19 pandemic when a lot of prevention measures were in place to prevent the spread of COVID-19, which impacted the circulation of other respiratory pathogens as well. So we did not have as much flu activity in general. So no outbreaks reported that season. And then 21-22, we had a total of 2 outbreaks, and 22-23, a total of 3. Next slide. And now I will hand it back over to Isaac to talk about influenza prevention measures.
Thanks, Elizabeth. So prevention of influenza primarily consists of vaccination. On the right-hand side of this slide, you can see CDC's current season flu vaccine campaign graphic, taking flu from wild to mild. And the point of that is really that the purpose of vaccines, and flu vaccine specifically, is that it can mitigate or make less severe flu illness if it occurs. it is very unlikely, I would say highly unlikely, that a flu vaccine would prevent flu illness altogether. But the purpose of vaccines is typically to reduce the severity of illness with the goal of preventing hospitalization or death. And that's part of why it's so important to have flu vaccination occur at the right time. And the flu vaccine this season is recommended for everyone 6 months of age and older, with rare exceptions. So no change in that recommendation for this season compared to last year's. And as I was alluding to a moment ago, the recommended time for vaccination is right now, the months of September and October. This doesn't mean that vaccination should not occur after October. CDC does recommend that vaccination occur as long as flu virus is circulating in order to prevent illness in those who may have not been vaccinated earlier. This season, the flu vaccines are all what we call quadrivalent, or protecting against 4 strains of the flu. At the beginning of this section, I mentioned that there's types A and B, and that we have 2 subtypes of each of those. So that's our number 4. And the flu vaccines this season are designed to protect against all 4. As is the case every season, whether the match between the flu vaccine and what actually circulates is a high match or a lower match can vary. Based on the data that we have from the Southern Hemisphere, which has an opposite flu season to us, it seems like this season's flu vaccine will be well matched, but we really won't know until activity starts and we start to collect data. The one recommendation that was new last year was that a high dose or an adjuvanted flu vaccine is preferred for individuals who are 65 years and older. So there are 3 different specific flu vaccine products that fall into this category, and more information on that can be found on the CDC's website. The reason for this is that there is waning of the immunity produced by a flu vaccine over the course of a season. And in general, in older adults, the immune system waning occurs in a more pronounced fashion. So having a high dose or an adjuvant in the flu vaccine helps to boost that initial immune response so that the protection lasts longer throughout the season. And then an important point, especially since there are many different vaccines right now for respiratory viruses, it's important to note that the flu vaccine can be safely administered with the COVID-19 vaccine. We won't be covering the COVID-19 vaccine update in this talk, but there are updated COVID-19 vaccines, and flu can be given at the same time as that one in particular. There we go. So as far as flu treatment goes, I just wanted to cover some of the basics of this. The particulars can be found in much more detail on CDC's website with regard to specific medications and their dosing and frequency and those type of things. But in general, flu treatment, the antiviral medications that are used for this work best when they're started within the first 48 hours after symptoms begin, because they really work to interfere with the replication process of the virus. And so when there's less virus present, it's much easier to contain that virus, shall we say, before it starts to replicate more and more. The way that CDC looks at this is among those who are at higher risk for complications and then those who are not as higher risk. And I mentioned some of those groups on the first slide in this section. So the second bullet point here, CDC recommends that treatment for someone with high risk complications can begin even before there's a confirmed diagnosis of flu. So that's the suspected influenza piece. And then, of course, confirmed for people who are high risk of complications, but then also those who might be having some complicated disease, progressive illness, so it's getting worse, or in the hospital. And so CDC gives that strong recommendation to treat with the medications that we have available in this situation. This is somewhat in contrast to the third bullet point here, where treatment can be considered. So it's not necessarily recommended by CDC for non-high risk people who are not in the hospital, outpatients, who have a suspected, so we don't have a confirmed test, or confirmed influenza infection, using clinical judgment. So the provider's clinical judgment piece comes in here. If that treatment can be started within the first 2 days of the first 48 hours of symptom onset. So really trying to give a little more latitude as far as whether treatment is needed. Really comes down to the individual and then the provider's assessment of that patient. And then lastly, there are 4 different antiviral medications for flu that are approved and recommended in the United States this season. There's the oral oseltamivir, which I think a lot of us are most familiar with. This is Tamiflu. But there's also an inhaled antiviral called zanamivir. There's another oral medication that's relatively new. It's a few years since it's been approved and on the market in the United States, called baloxavir. It works a little different than the other antivirals on this slide, but it's also available. Notably, it's a single dose that's used to treat as opposed to dosing for several days. And then lastly, there's the antiviral peramivir, which is given intravenously. But also Tamiflu is the most common that we see and most commonly available for treatment and prophylaxis in situations where that is necessary. And with that, we're going to switch over to a different pathogen. We're going to move now to respiratory syncytial virus, or RSV as we commonly know it. This is one that has come to greater awareness maybe in the last year or so, given the season we had. And Elizabeth will talk more about that in a bit. But RSV is an area of exciting development as well, particularly in the realm of prevention that I will be discussing in a bit here. But first, let's level set with some basics about RSV. In some ways similar to flu, there are 2 main types of RSV, A and B, that are present and infect humans. We don't know as much about how these circulate, although there's a lot of work underway to understand how much RSV-A versus RSV-B occurs in a given season in a given place. Generally, we think of them as causing similar severity of disease and not necessarily preferring one population over another, but really a lot of that is not known right now, and we're trying to learn about it. I should make a note about the name here for a moment, respiratory syncytial virus, which is always a little tricky to say. The word syncytial comes from the way that this virus causes cells to form a syncytium after being infected. And that's what this picture is on the slide here, is a syncytium that has been caused after an infection with RSV virus. Shorthand RSV is fine. People know what that means. But in case you were curious about the background on syncytial, that's where it comes from. You'll see that here that the symptoms for RSV are very similar to influenza. They're usually more mild and cold-like, especially in adults. Runny nose, poor appetite, coughing, sneezing, fever, wheezing, and those who might have a predilection to wheezing due to underlying conditions or not. And these symptoms typically start 4 to 6 days after an infection has started, and the contagious period lasts about 3 to 8 days after symptoms start. This is a bit longer range than some other viruses, although it can depend on the individual as well, especially those who might have an immune system issue, an immunocompromising condition. The contagious period can last for a lot longer. Similar to flu, the transmission through virus-containing droplets and also contaminated surfaces are thought to be the main route, although there's definitely airborne particles that can spread RSV as well. Primarily, it's thought right now that droplets and contaminated surfaces, which we sometimes call fomites, can transmit this too. I'll put a big asterisk here and say that there's a lot that we're still learning about RSV, and there's a lot of attention on it, been a lot of attention, and there is right now. So some of this information could change as we continue to study, but this is our best understanding right now. Similar to influenza, the groups that are at high risk for severe RSV disease after an infection include the extremes of the age spectrum, infants and younger children, and then older adults. Particularly, I will emphasize infants because due to the size of their airways, just the anatomy, their airways being small, RSV can cause more severe illness more in a higher incidence of it than in other populations, but definitely it's an important cause of severe illness, respiratory illness in older adults. And then, of course, those with certain underlying conditions, respiratory conditions, as well as other systemic issues too. All right, with that, I'm going to hand it back over to Elizabeth once again to talk us through some of the epidemiology and data.
Great, thanks, Isaac. So yes, I will be talking about RSV surveillance in Colorado. So the above graph shows trends in RSV hospitalizations in adult and pediatric patients in Colorado, starting with the 2021 season to present. And one thing I'll note here that I will also explain more in depth on another slide is that this data is actually only collected from the 5-county Denver metro area. So that includes Adams, Arapahoe, Denver, Douglas, and Jefferson County. The reason for that is we work with the CDC's Emerging Infections Program. And what we do is we collect data on hospitalizations reported from this specific area because it comprises roughly about 50% of the statewide population. And RSV just became reportable in 2019. And so since then, we've only collected data from those 5 counties. That has changed as of this past year. But just for reference, these admissions just show data that's collected from those particular counties only. So you can see here that pediatric patients are the predominant age group or category of individuals affected by RSV or admitted to hospitals for RSV. And the 21-22 season was a fairly moderate season in terms of hospitalizations, similar to influenza. Both pathogens had fairly moderate levels of circulation in Colorado, as well as nationally. And however, the 22-23 season was significantly more severe. And I will say that the rates of RSV that we saw last season, which activity started kind of around August, mid-September. And then we saw peaks around the end of November, early December. This was definitely the highest rates that we have seen since RSV became reportable in 2019. And one thing to note, as Isaac mentioned, there are the different subtypes of RSV A and B. And the majority of testing platforms in hospitals don't necessarily always differentiate between those two strains. So again, we have limited data on how RSV-A versus RSV-B contributes to hospital admissions. Next slide. So similar to the influenza positivity slide, this shows the percent positivity of RSV in Colorado from October 2022 to present. And as shown on the previous slide, again, this data is reported weekly from the 26 Sentinel Hospital laboratories across the state. And again, they indicate the percent positive RSV specimens among the total number of specimens tested for RSV at that lab. And currently RSV positivity is extremely low. It's at about 0.17%. And just for reference, when we talk about positivity levels, what we sometimes see, particularly with influenza positivity, high levels of positivity can range anywhere from maybe 20 upwards of 30%. It's not throughout the whole season that they remain at those levels, but just for reference, when we say that RSV positivity is low, a 0.17% is pretty low. And so I think last year, the maximum positivity, as you can see, we saw upwards of about the 23%. And the other thing I'll mention about this slide is we did see an increase in the number of outbreaks reported from schools and childcares. And that activity really started in about August of 2022. So when you see the October 22 trends, you can see that clearly there's activity that began before that time frame, which we generally don't always see. Most of the time in past seasons, since RSV has been reportable, activity generally starts around October, maybe November. So last season was definitely an early start as well. Next slide. And to review the reportability of RSV conditions in Colorado, as I mentioned before, so RSV recently became reportable in terms of hospital admissions and outbreaks. So in 2018-19, that was considered our pilot season. And so we only had RSV-related admissions reported from the UCH Anschutz Hospital and Children's Hospital Colorado, both located in Denver. And this was in collaboration with CDC's Emerging Infections Program. So the pilot season only looked at hospital admissions from those two particular hospitals. And then beginning in the 2019-20 season, that is when we made hospitalizations for RSV reportable among residents of the 5 metro area counties only. Again, that is Adams, Arapahoe, Denver, Douglas, and Jefferson. And that is how reportability has been up until the end of this past season. So beginning in June 18th, or on June 18th of 2023, hospitalizations became reportable statewide in Colorado. And so we're looking at data not only from the 5 Denver metro area counties, but all counties across the state. And then one thing to mention about outbreaks, so beginning in the 1920 season is when RSV outbreaks were also, they also began to be reportable statewide. And we track outbreaks in long-term care facilities, schools, and child cares. And one thing that I'll also go more into depth about is RSV outbreaks in correctional facility settings are not actively tracked. However, if one occurs, please notify us and or the local public health agency. And I'll discuss that in a little more depth here in a moment. Next slide. So just to show some of the outbreak trends for RSV, so this is looking at last year from October 2022 to May 2023. And so this graph shows RSV outbreaks by the setting type and the week of onset. And so you can see here, several outbreaks occurred among schools and childcare facilities. That is where the vast majority of outbreaks are reported, since RSV impacts the pediatric population the most significantly. However, we also tend to see RSV outbreaks occurring among the elderly population, which again is another group that is susceptible to RSV as well. Again, as I mentioned before, correctional facilities, we don't actively track and monitor RSV outbreaks because the population within correctional facilities, it doesn't always comprise, youths or pediatric cases. And generally speaking, there may be older aged individuals as well. But generally, RSV is not something we commonly see occurring. And so just for comparison, the table on the right shows RSV outbreaks by season in each different setting type. And so long-term care facilities, we definitely had several of them last season with 31. Another thing to note is during the 2021 season, similar with influenza, we didn't have any outbreaks reported in long-term care or schools. You can see how the trends have gradually increased since then, however, or actually markedly increased last season. So we had roughly 31 long-term care facility outbreaks and as many as 454 school and child care outbreaks. We did have one outbreak reported from a correctional facility last season. So again, we want to reiterate that even though it's not something we typically see or typically track or monitor, it is something that we want to be notified about because we may still need to provide support and guidance with mitigation measures for it. Next slide. And so to discuss outbreaks in correctional facilities a bit more, so we have our Colorado outbreak guidance for long-term care facilities for RSV. Additionally, we have outbreak guidance for influenza outbreaks in correctional facilities. But our guidance tends to just focus as needed on those facilities that serve populations that are the most severely affected by RSV. And generally, again, that includes infants and young children and older adults, which may make up a lesser part of the incarcerated population. So again, these outbreaks are not actively tracked by public health. However, all instances of outbreaks of communicable disease are still considered reportable. So we may not assign an outbreak number. It may depend on whether or not we put it into our database or report it in our yearly surveillance reports or things like that. But we do want to know about these in case we do need to assist. And again, we just had the one RSV outbreak reported last year. Next slide. Okay, and so just to review the outbreak definitions that would be put in place should an outbreak occur. It's similar to the influenza outbreak definitions, but a suspect outbreak would be if you had one confirmed case of RSV among residents, among one or more other residents, or actually this should say IDP, with undiagnosed respiratory illness with symptom onset occurring within a 1-week period. And then a confirmed outbreak, again, would be 2 or more confirmed cases of RSV among IDP with symptom onset occurring within a 1-week period. Next slide. And so one question that we do commonly get is in regards to testing in correctional facilities. So in the event of an outbreak of an unknown respiratory illness, individuals that are experiencing influenza-like illness, which could be cough, fever, and or sore throat, should be treated as potential COVID-19 cases until testing proves otherwise. And so Testing for viral respiratory pathogens may be provided by the CDPHE state lab on a case-by-case basis. So if you have an outbreak occurring, we can provide testing. We have a couple of different assays at our lab and viral panels that we can use. We do ask that you contact the local public health agency as well as our team prior to submitting any specimens, just to ensure that our state lab has the capacity to run these tests and also to determine how many tests we'll actually be needing to run. And if testing proves to be negative for COVID-19, then we recommend testing for influenza and or RSV as appropriate. And then one other thing to keep in mind is that co-infections of COVID-19, flu and RSV can and may occur, as well as co-outbreaks. So we have had instances where there are COVID-19 outbreaks happening simultaneously to flu and or RSV. Next slide. And now I will pass it back to Isaac to talk more about RSV prevention products.
Thanks, Elizabeth. All right, so this is a newer area for us this year in the United States. Prior to this year, 2023, there would be only one product that was available to actually prevent RSV. And that product was a monoclonal antibody, so antibodies that are made outside of the body and then given. And these were given just to very high-risk infants and young children to help prevent severe RSV disease that could lead to hospitalization. But it was very limited. And this year we've had a real explosion in prevention products for RSV over the course of the last few months. So I'm excited to talk about these and help to increase awareness about these products generally, but also in particular ones that might be applicable in this correctional setting. So the first sub-bullet point there, RS vaccines for older adults. I'll talk a little bit more about these on the next slide, but there are 2 different RSV vaccines that have been approved and recommended for use in adults 60 years and older. And these are for individuals who are at higher risk of severe RSV disease in that age group. These 2 vaccines, either one is recommended depending on what's available. And it does depend a bit on it should occur in the context of a discussion between the patient and the provider, understanding all the factors at play. But this is really focused on that end of the age spectrum that can see a significant morbidity, severe disease from RSV, although it's a bit different than what is seen relative to the younger kids. So that leads into the last 2 bullet points here. The prophylactic monoclonal antibody, this is a product that is called nirsevimab. The trade name is Beyfortus, but it's similar to what we had before, the older monoclonal antibody that's been around for a while now was known as Synagis or palivizumab. This is a new one, and this one works more effectively than Synagis did. And it's actually been approved and recommended for all little ones, infants who are going into their first RSV season, who are younger than 8 months old at the start of the season, or they're born during the season. This group is really the highest risk for severe RSV disease, being hospitalized for RSV, and this monoclonal antibody that is made synthetically and then given by an injection has about an 80% effectiveness at preventing hospitalization in these little ones. It's important to note this is not technically a vaccine. Vaccines cause the body to produce their own immune response, their own antibodies. This is a pre-made antibody that is then given by a shot still to these little ones. There are also some who are a little bit older, 8 to 19 months of age, who are at higher risk, who are also recommended to get this in a second season of RSV. But primarily, the largest group is going to be those newborns and young infants who are going into their first season, just to make you aware of this new product. And then the last one on here is an RSV vaccine that is given during pregnancy in order to give protection to the newborn after birth. So this is actually one of the same vaccines as is recommended for older adults. It's just that this is given during pregnancy between 32 and 36 weeks of pregnancy. And the idea is that the mother then generates an immune response, and those antibodies are passed through the placenta to the baby while still in the womb. And then for the period of months after, 3 to 6 months after, there is protection against severe RSV disease for that newborn. This is not a brand new concept. This is the same idea behind vaccinating for flu in pregnancy, and then having protection for the newborn, or indeed vaccinating against COVID-19 during pregnancy. It applied to a different pathogen this time, still protecting that youngest age group. So these are the three new RSV prevention products. And the one that is going to be potentially more applicable in the correctional setting are the ones for older adults, although this could vary in terms of who is in the setting. Adults age 60 and older receiving a single dose of RSV vaccine using shared clinical decision making. So like I said before, the highest risk for severe RSV disease are likely the ones who will benefit the most. That's kind of common sense. But what we're really trying to do in this recommendation is target those who are most likely to benefit. They're still collecting data about these vaccines. They are safe and effective, which is why they've been given full approval and recommendation for use. But there are still some things that are being understood about entirely who benefits the most, and also all of the pieces regarding safety. In particular, there were some events of what we call neuroinflammatory events in the trials. That's maybe a fancy way of saying neurologic side effects that are not totally understood based on the numbers that were enrolled in those trials. But it still seems to be safe and effective for those who would be at highest risk for severe RSV, those with underlying conditions, and those that are older. All of that to say, the purpose of a shared clinical decision-making recommendation is that, as with many other things that providers do with patients, it's a conversation between the patient and the provider. And in that conversation, talking about the vaccine, talking about the pieces of an individual's health history that are relevant, and then making a decision together about whether this RSV vaccine makes sense for this person. The individual's healthcare provider is also going to be one who can help navigate insurance coverage questions with these vaccines, since they are new. Some of that is still being worked out, but that is something that can be discussed on an individual basis. All right, now for treatment of RSV. Unfortunately, this is one area where we still need progress to be made. We don't have antiviral medications like we do for flu or COVID-19. The two examples you see there on the bottom are Tamiflu, oseltamivir, or Paxlovid, which is ritonavir boosted nirmatrelvir. We don't have those kind of antivirals available for RSV. So when an individual has an RSV infection, the primary way of treating it is supportive, helping them with respiratory support if needed, maintaining hydration, and managing all the other symptoms that occur. And yeah, I do hope that this is an area that has some progress in the coming years. There are things under research, but I'm not aware of something coming soon. All right. And with that, I think we've covered most of our content for today. This slide is just a resource slide to our dashboard, which shows our data that Elizabeth was talking about earlier. Her team is the one who works on that and updates that dashboard weekly during the season. So here in a few weeks, it'll start to get updated. There's also some CDC dashboards here that you can look at for a more national picture of flu and RSV hospitalizations. And then as mentioned earlier, the guidance for flu outbreaks in the correctional setting is currently being updated and approved and should be released soon. And our team email there is at the bottom. That's the easiest way to reach all of us. Individuals can be reached through that as well. So please reach out via that link, via that email address if there are follow-up questions. And with that, I want to thank you all for inviting us to come talk about some of this for the last hour or so. And I don't know if there's time for questions or what questions may have come in, but we're happy to try to address those too.
Hey, Isaac, I don't see any questions in the chat, but we do have a few minutes. If anybody has a question for the presenters, go ahead and type it in the chat. In the meantime, I relinked the training evaluation survey for our attendees to complete since they attended. And we'll also be posting the recording and the training materials once those are completely final. And we'll make sure to share out those materials and where they're posted when we're ready. So I don't see any questions at the moment, but I'll give another minute. Okay, I don't see any. Andrea, I don't know if you have anything else?
No, I do not. Thank you.
Thank you all for attending, and thank you to our presenters.
Thanks for having us.
Yes, thank you so much.